So next disease condition is oligohydramnosis. So hydramnosis is some of the diseases or abnormality that may decreased or increased amniotic fluid during the time of pregnancy that will comes under the hydramnosis. There are two are there, that is polyhydramnosis and oligohydramnosis. So today we are going to discuss regarding the oligohydramnosis. So normal amniotic fluid, about 12 weeks of pregnancy, nearly the amniotic fluid will be about 50 ml of amniotic fluid will be there. Then by 20 weeks it will be 400 ml, and by term, that is 36 to 38 weeks of gestation, that will be reaching till 1 liter. So this is the amount of amniotic fluid calculation in the pregnancy. So what may happen means how the amniotic fluid will be developing. So one content of the amniotic fluid is fetal urine. Baby may pass urine and that may contribute to the amniotic fluid. Then fetal lung secretions and oral nasal secretions and all will be contributing to the amount of amniotic fluid. As the fetus will be growing, the amniotic fluid amount also will be increasing, and by term 36 to 38 weeks of gestation, the amniotic fluid will be around 1 liter. So how can the amount will be controlled means the amount of amniotic fluid will be controlled by fetal swallowing, intramembranous transfer, transvenous membrane transfer. So next one is the amniotic fluid index. So the total abdomen of the mother will be divided into 4 quadrants, and from each quadrant how many centimeter pocket you can count, fluid pocket you can count, like that you will be counting the amniotic fluid. So like 8 to 24 centimeter is the normal amniotic fluid. So oligohydramnosis, it is defined as reduced amniotic fluid. Oligohydramnosis is defined as reduced amniotic fluid. So oligohydramnosis means it is the reduction in the amniotic fluid is called it as oligohydramnosis. That means the amniotic fluid volume will be less than 200 at term, and AFE, that is amniotic fluid index, will be less than 5 centimeter at 28 to 40 weeks of gestation. The amniotic fluid amount is dramatically reduced and the amniotic fluid index is less than 5 centimeter. This condition we will call it as oligohydramnosis. The causes of oligohydramnosis are maternal disease conditions like hypertensive disorder, uteroplacental insufficiency. From the uterus through the placenta, there won't be sufficient amount of blood won't be getting to the baby. The perfusion is low, the amount of the blood will be fluid will be low. Then there is dehydration in the mother, idiopathic causes, and postpartum pregnancy. That postpartum pregnancy means pregnancy exceed beyond 40 to 42 weeks. That is called it as the postpartum pregnancy. Then pre-labor rupture of membrane, early rupture of the membrane. So these are some of the maternal causes of oligohydramnosis. Oligohydramnosis is the reduction in the amniotic fluid less than 200 ml at term, and the amniotic fluid index will be less than 5 centimeter. So some of the fetal condition, fetal renal agenesis, urinary tract obstruction, because urine is also a main component or the source of amniotic fluid. Then spontaneous rupture of membrane, intrauterine infection, IUGR, and drugs like iatrogenic causes, idiopathic causes we discussed, like drugs like prostaglandin inhibitors, AC inhibitors, fetal chromosomal and structural anomalies, amnionodosum. So these are some of the fetal conditions that may leading to oligohydramnosis. The clinical features of oligohydramnosis are the fluid will be less, so the smaller uterine size. Than the period of gestation, the uterine size will be small. Then less fetal movement, because the baby is not having adequate space to move, the fluid will be very less. Then the uterus is full of fetus. So if the uterus will be filled with the baby and more fluid, it is very difficult to palpate the baby. But here the amniotic fluid is very low, so the uterus is very small and we will feel that the uterus will be filled with full of fetus. And there is malpresentations and also evidence of IUGR will be there. Then the diagnosis are history collection, then diagnosis of watery, blood-stained vaginal discharges, hypertension, preeclampsia, pre-gestational hypertension, then family history, congenital anomalies, chromosomal abnormalities, and some of the medication history should be collected. So how can you diagnose means, during the antenatal examination, you should do the physical examination, small uterine size, less fetal movement, uterus is full of fetus, malpresentations, and intrauterine growth restriction, and ultrasonographically you will be counting the vertical pockets of amniotic fluid. We will be dividing the abdomen into quadrant and 4 quadrant, and each quadrant how many vertical pockets of fluid will be, that ultrasonographically we will be assessing. That is called it as amniotic fluid indexing. So that is less than 5 centimeter. So normally it is 5 to 24 centimeter. Okay, so then we can suspect that like oligohydramnosis. And if you go for speculum examination, the vagina, watery vaginal discharge can be identified. Then the complications are maternal complications like prolonged labor due to inertia, then increased operative interferences. We may be needing to go for some of the operative interventions if there is a malpresentation and chorioamnionitis infection is there. Then fetal complications like congenital anomalies, chromosomal abnormalities, fetal growth restriction, intrauterine death, intrauterine infection, especially if you go for a premature rupture of membrane, then prematurity. Then due to reduced amniotic fluid volume, there is a chance of skeletal deformities, contractures, amniotic band and accumulation, then pulmonary hyperplasia, umbilical cord compression, meconium aspiration, fetal heart rate abnormalities, low Apgar score, and intrapartum death also can be identified. The management include the first trimester counseling to the woman and serial ultrasonography periodically to assess the condition of the woman can be done. In the second trimester also counseling regarding the disease condition, support, psychological support, everything should be given. Then consider the amniotic infusion. So what even be amnion infusion means, under the ultrasonography how we do the amniocentesis, same like instead of proving the amniotic fluid, here we will be administering some amount of fluid like normal saline and all into the uterine cavity through ultrasonographic guidance. So that is called it as amnio infusion. Then serial ultrasonography, periodic ultrasonography should be done, and try to explore pre-labor rupture of membrane and termination of pregnancy whenever necessary. If the termination of pregnancy is needed, then go for early termination of pregnancy in the second trimester itself, with the trying to the survival of the baby. So in the third trimester, what are the things? Deliver postpartum cases. If it is reason for hydramnosis is a postpartum pregnancy, that is it exceeds 40 weeks or 42 weeks more, so terminate the pregnancy. Then ultrasonography and Doppler study for IUGR should be done. Then conservative management in case of preterm. If it is a preterm baby, it is not completed 37 weeks of gestation, conserve the pregnancy by some measures like amnio infusion and all. Then pre-labor rupture of membrane till 34 weeks. At least wait for 34 weeks of gestation. So preterm, once the baby becomes term is 37 weeks, at least you should wait for 34 weeks. Then idiopathic cases, like in that cases and all, non-stress test, ultrasonography and biparatal like BPB, biophysical profile like ultrasonography, fetal movement, like that modified biophysical profile in the fetal well-being we already discussed, that should be assessed. The specific measures to increase the amniotic fluid volume are maternal hydration. So like intake of 1500 to 2000 ml per day oral or IV infusion of fluids in order to improve the maternal hydration can be done. Amnio infusion, that abdominally or transcervically give enter into the amniotic cavity and infuse some amount of fluid into that. See this picture, you can see. Okay, amnio infusion. Okay, under the ultrasonographic guidance. So these are the things you can do in case of like oligohydramnosis management. Okay, then what are the things you should do in the oligohydramnosis management? Ultrasonography to exclude the placenta, painting and draping of the area, a 20 gauge needle that is connected to a sterile tubing with a 50 ml of syringe. So normal saline should be injected under ultrasonography. So if it is a Rh negative woman and all, anti-D immunoglobulin can be there. Sometimes placental site injury or some labor is imminent, sometimes that complication may happen. So in case of Rh negative mother, if necessary, administer anti-D immunoglobulin. So the nurse's role include constant assessment of the woman should be done. Then baseline fetal heart rate, vital signs, uterine activity, monitor fetal heart rate and uterine activity, measure and mark fundal height, notify the resolving condition. If there is variable deceleration, 800 ml of solution is infused also, there will be variable deceleration in the fetal heart rate. Then non-reassuring maternal or fetal response, and intrauterine pressure will be more than 25 mm of Hg. So these and all should be assessed. So the timing of delivery according to the fetal condition and specific condition. If preeclampsia, growth restriction, fetal anomalies is there, the plan of delivery will be changing. According to the baby condition, mother condition, the delivery plan will be changing. So close monitoring of the baby by fetal heart rate monitoring, rupture of membrane in active phase of labor, amnio infusion in case of meconium state, and fetal heart rate abnormality, immediately go for cesarean section. The nursing management include daily fetal movement count should be done, fetal lateral position. So advise the mother to lie in left lateral position. Fetal monitoring should be done periodically. Administration of fluids to maintain the hydration. Then anti-D immunoglobulin after amnio infusion if necessary. Close monitoring during the labor. So these are the management can be done. So the nursing diagnosis include risk for fetal compromise related to reduced amniotic fluid volume, risk for prolonged labor related to uterine inertia, risk for infection related to premature rupture of membrane, anxiety and ineffective coping. So these are the management. So thank you. So this is about the oligohydramnosis, decreased amniotic fluid, that is less than 200 ml, and the amniotic fluid index will be less than 5 cm. So this condition is called it as oligohydramnosis.